So the last speaker that we are going to be listening to is basically Professor IR Dr. Huang, also from the Department of Mechanical Engineering, Faculty of Engineering. He'll be talking to us about Guide to COVID-19 for Healthcare Buildings, ASHRAE Epidemic Task Force. So Professor Dr. Yao is basically obtained his Bachelor of Science in Mechanical Engineering cum laude honors degree in 1994 from Wichita State University in Kansas, USA, and Master of Science in Mechanical Engineering in 1996 from University of Science, Malaysia, Penang. And he continued with his Doctor of Philosophy in Mechanical Engineering in 2005 in University of Canterbury, Christchurch, New Zealand. And also he was a prestigious NZ8 PhD scholar for 2001 and 2004 at University of Canterbury, Christchurch, New Zealand. Without further ado, Prof. Yao.
Yeah, so well today I'm going to talk about this, the guide to the COVID-19 for healthcare buildings. And this guide is actually from the ASHRAE Epidemic Task Force. ASHRAE is actually a professional body from the US, unit from the United States. Okay, so let me see the outline. So what we'll do today is what are the practical approach to reduce the risk of infections by ventilations. Okay, the unique areas, because hospital is a very unique areas. They like previous two speakers, what they have say, in hospital there are number of unique areas, like you have operating theaters, you know, and you have ICU, you have general wards, you know, you have office area, and you have the nurse areas, you know, all this come with a different specification in terms of ACMV system. ACMV system is a air conditioning mechanical ventilation system. So that's why it is a very complex system, like what Dr. Humidity say in her previous presentations, very complex. And in Malaysia is even hard. Why is that so? Because we have very hot and humid conditions, and the humidity is very high and very unique. Okay, very unique. Is a full tropical climates. Okay, then such areas basically how we exhaust out the contaminants. Okay, we need to exhaust out the contaminants. If we have the stagnant A, stagnant C inside there, we need to get it out quickly so that it will not be there for a long time. And if there is an airborne, it will be very dangerous. And of course, then there will be maintenance that I'm going to touch on. And of course, there will be you know, in the hospital there will be medical gas, vacuum system, you know, and others. So I'm going into the slide so that everybody can see the slide. And okay, can you see my slide here, Prof. Victor? Can you see my slide here?
Yeah, I can see your slide.
No, I go into my PDF slide.
Sorry, which slide?
PDF. My PDF.
Oh, this one, the one on the screen you saw. All right. Basically,
okay,
you have removed the slide.
Yeah, I'm going to the PDF slide.
Okay, just
okay. Yeah, this is a PDF slide. All right. You see, from the ASHRAE Epidemic Task Force, of course, this is a very lengthy guides. I don't have time to go through one by one, but I will go straight to the approach, you know, practically. Because we, like I say, we don't have much research on this COVID-19, you know, don't have much research. And suddenly it has been here for 1 year already. So, but from our experience as a practicing engineers, we know these are the practical approach. Now, you see, passive isolation is one of the approach. Okay, passive isolation from the CDC in the US. Okay, so you know that one patient per room. You don't want to have more patients in one room, so that to reduce the risk. Okay, close the door, implement rated CDC safety protocol. Okay, so this one I think we already practice here in the hospital. Am I right, Prof. Victor?
Yes.
Yeah, so I think we already practice here. Okay, so then we see this airflow from clean to less clean. So the airflow now, because you see the problem is our ventilation system, some of the ventilation system in the hospital, we have a return air. Return air mean the air actually return to the return grill and go back to the mixing box. So that I think because of COVID, we need to we need to make it 100% fresh air. So somehow in this scenario, the hospital engineering team need to actually go and modify it, okay, to make it 100% fresh air. Like I noticed that some of the participants actually they ask how to be safe, in a space like this. One way is to actually make it 100% fresh air. That means you don't have a return air. So the air coming in then get out. There's no return air. So that is one of the way, and it can be done for the central system, but not for the split system, because split system basically is 100% return air. So that is dangerous to have a split system in the hospital. You see, I mean this particular time with COVID-19, I think is pretty dangerous with a split system in the hospital, because you have 100% return air. And most of the split system just 100% return air, so then they don't have a dedicated fresh air. So that's why there's a high risk there. Okay, so the air change rate. I will recommend at this time, usually in a normal watt is 15 ACH, 15 air change per hour. Okay, in operating theater 25 air change per hour, I will recommend in the OT you go up to 40%. 40 air change per hour. So that is very but in the OT anyway is it's 100% fresh air anyway, which is negative pressure. So you should go up to 40 SCH. That means the maintenance teams or the engineering team from the hospital have to increase. Okay, increase the air change rate, air change power, ACH. In short term is ACH. Okay, so and filtrations. In OT you have a HEPA. Okay, and OT. Depending on how many outlets you have. Some OOT you got only one outlet. I think that one is a bit risky because you have air stagnancy there, and when you have air stagnancy, then if you have airborne, because COVID-19 is airborne, you see, if it is inside there, then it's dangerous to the patient, to patient, and also to the healthcare workers, to our doctors and nurses. Because when you have air stagnancy, that means the COVID-19 airborne will be there circulated, and it is still there, after some time. It's not going out there, through the filtration system, through the HEPA filter. So this is a risk. Okay, I mean, in this case, we have to increase the VFD. In term, you can see my highlight here. VFD is a variable frequency drive. Okay, the fan speed. All right, so I believe in hospital usually you have this level of filter efficiency, MER. MER 14 to MER 16, slightly lower than HEPA filter, but most of the time you have this, okay, which is the filter efficiency is 14 to 16. Now, there is also another thing in the hospitals. We have to make sure that the RH, relative humidity, is 40 to 60%. And in Malaysia, is another challenge to us. Why? Because our humidity is very high. And if we have exceeded 70% or 70%, you have problem. Because not just COVID-19, we also have fungus, you know. So you have fungus grow in the hospital, and at the same time you have COVID-19. So that is a challenge, you know. There's a challenge in our hot and humid conditions, and we have to maintain this at 40 to 60% using a bigger coil. The coil to size it bigger so that we can get rid of the moisture. We have to get rid of the moisture. Okay, now we go back to the okay. Okay, so this is another. Can you see my slide, Paul Victor?
Yes.
Okay, so
guidance on recirculation.
Yeah, correct. So we have to have a, like I said just now, we have to have 100% fresh air. You know, used to be doesn't mean that every area in the hospital we need to have 100% fresh air, but because of COVID-19, I think at this time temporarily, you know, we have to switch to 100% fresh air. There's no choice to reduce the risks. Okay. Okay, so this is the typical HEPA filters, high efficiency performance filter, HEPA filters. And usually this one you only find in the OT, operating theaters, okay, operating theaters. And I think because of COVID-19, probably most of the area you have to have this one, HEPA filter, because this will filter 99% out of the aerosols, the virus. Otherwise, the risk is there. So this is the typical HEPA machines that you can have. And like I say, the air purifier actually with this already available in the market, in fact, and you can go and sort it, and it is available in the market. Okay. This is how the HEPA filter perform. Okay, I will skip this. Of course, the CDC also advised the use of PPE. You know, the use of PPE. So I think this one we already practiced. You know, with N95. You know, masks. Okay, so the maintenance for hospital, I think is crucial. It's very crucial, and we have to keep on changing the filter. You know, every 3 months. Make sure that we change it. Okay, so now go back to the. Okay, so this one I will show everyone the, you know, how we suggest to the hospital. Okay, this one can also apply, some of the option can also apply to the clinic, you know, the private clinics. If you are from the private clinics, you know, shop lots, this could be applied as well, how we do it. So option one, you see, this is how from the in room, you can use a HEPA discharging directly to exterior, but of course not to the, you know, to the sidewalk, because it will be dangerous, risky to the, you know, to occupant or someone, you know, someone use the sidewalk. You have to discharge through a hood, you know, through a safety hood, ventilation hood. So this is option 1, if you can see that. Okay, option 2. Okay, this is the, you look at my cursor here, this is how you do. In room fan, non-HEPA, discharging directly to exterior or use existing room exhaust. Okay, so this one, if I can show you a video, that's better I show you a video, okay? There's a video available for this, so that you can see from the video. Couldn't find the video, that's okay. Okay, so these are the few technical, we call it mechanical units in the ACMV system. You can see that this one is fan coil units, the heat pump units, the package terminal air conditioners, and expansion coil DX and mini split DX units. So in the hospital, I can see that many of them are actually, if you look at my cursor here, this is a ceiling cassette units. Many of the system actually they just use ceiling cassette units with a VRF system, okay, variable refrigerant flow. So that could have a risk because VRF, it doesn't come with a dedicated fresh air system. So there's no fresh air coming. That means the air is 100% recirculated, return air. So it's a risk during this time. You know, during a normal time, no COVID-19 is not a risk because there will be infiltration and exfiltration. There's no issue. But during COVID-19 is a risk. Okay, so that's why you see this. If you see this one, that means in your, let's say in your space, you come with a cassette unit like this, and you don't have a dedicated fresh air system, then or you know something to exhaust out, then it will be a risk. You know, correct? Prof. Victor.
But no, basically yes, it's correct. But some of the cassette system includes exhaust vented. Basically, if you look at some wards, they have cassette system. But
Yeah,
we don't have cassette system in hospital, but in clinic, some of them do have cassette system. But those cassette system they include exhaust what call that, connection to the outside.
that will be better. Otherwise, if it's just a cassette there, just doing cooling, and no exhaust, you know, no exhaust fan to exhaust it out, that is dangerous.
Yes.
Because the airborne will be there, right? And will not be exhaust out.
Correct.
Yeah. So this is a split system. Look at my cursor here. This one is a split system, and I noticed that also commonly used, very commonly used in the hospital and also in the clinic. Clinic. If you are clinic, and most of the time they just use this split system, you know. So that also another high risk. Okay. Now, okay, let's go back to the. Okay, this is what ASHRAE recommend, if you have a patient, is recommended to have a single patient room, no, versus multiple occupancy, for safety reason. Okay. Okay, so let's go to this one. I'll go quickly because this video is a bit lengthy. I just want to show you how they do it. Okay. Now, yeah, this is. Prof. Victor, can you hear the sound?
No. There's something wrong with it's very difficult to share sound. That's a problem.
Okay, let me see whether I can share the sound.
When you share the presentation, there's a audio at the top.
Audio at the top.
Stick to the audio.
Is okay. Just let me see where.
And it will come up with the audio.
Okay, I got it, but I need to go to the video.
Scientific protocol that went behind.
Can you hear the sound?
Of this
Yes.
solution.
Yeah. Okay.
First, we started out using a qualitative smoke, and through that we can watch the smoke and see what the airflow patterns are within the hood and whether the smoke stays contained within the hood itself. What you can see here, as the smoke starts to come out, is it's a nice gentle airflow back into the hood. We release these microscopic beads into the air using a medical nebulizer. We then activate the nebulizers, and you'll see the fog that's coming out of the nebulizer. But what you'll also notice is that the fog dissipates very quickly within just a couple of inches. At that point, the water has evaporated, and the only thing left are the beads. You can't see them in the picture, but they're there, and they're floating around the room now. What we can do to see those beads, though, is to use what we call an aerosol spectrometer, and we can tune that spectrometer in to focus only at the size of those beads. And by doing so, we can do measurements of how many of the beads escape into various sampling positions in the room. So the real science was when we took the study to the field, and we went to 4 different Midwestern hospitals and tested the ventilated headboard. And when we did that, you can see a graph here that shows the setup. The 2 red dots, that represents 2 different nebulizers. We put one on each side of the mannequin's cheek, and that was our source. That's where the small beads that I talked about earlier. Each of the yellow circles you see here are spots where an aerosol spectrometer was placed, and they would do measurements of the aerosol concentration, specifically looking at that 2 micron size that I talked about. But in each case, you see geometric mean reduction ratios of point.
Okay, I want to make it quicker so that you see how actually the product, how they do it. Okay, this is the one how eventually it should be.
The actual migrations or the ideas that came to mind then was to take this concept into the emergency medical shelter type environment. And with just a few modifications, we were able to adapt the hoods for that kind of environment. We have a ducted system here, so now all of the exhaust is going into the headboard, but then it goes into a single duct system to a single HEPA fan for final cleaning. The fan system, in addition to the fact that it's capturing the source here at its generation point, it's also cleaning the room air as a whole. So we have local source control, but we continue to have the benefit of the room dilution filtration. One of the things we can also do to augment the canopy hoods is you can add a second layer of containment. So if we were to take a pop-up tent, like a picnic tent, and add a sidewall kit to it, we would then have the tent inside the tent would be under negative pressure, and it adds a second layer of containment for this zone. So there are several components that make up the ventilated headboard. The canopy is an important component for a couple of reasons. One, it's what allows us to use such a low velocity of airflow to control the contaminants, and that way we're not bothering our patient. It also protects that low velocity airflow from being disrupted from air currents from an HVAC system or people or equipment that might be moving by and causing air drafts. It's fairly easy to replace the canopy were it to get soiled or torn. It has retainer clips here along the perimeter and in the back and along the sides. You remove those clips, cut out a new piece of plastic, put the clips back in place, and it's good to go. The canopy retracts so that the healthcare worker still has access to the patient's head for healthcare activities. And in doing so, it covers part of the filter that's behind it. And by doing that, it allows the velocity through the remainder of the filter to increase and go through faster. This allows there to be still a certain level of protection for the healthcare worker, even when the canopy is in a retracted position. The pre-filters that you see here, these are standard sizes, just like you'd find at almost any home improvement store. The purpose here is a little bit of pre-cleaning for the HEPA filter as a pre-filter, but the most important function for them is they distribute that low velocity airflow across this full dimension. If we didn't have this filter in place, the majority of the airflow would just go right into the center, and then it wouldn't be that nice even flow of air into the entire canopy surface. It has a lightweight extruded aluminum frame plus lightweight panels to create the filter box for the ventilated headboard. The height of the frame is easily adjusted using a simple T-handle wrench, and we can adjust the various bed heights or cot heights depending on what you're using. At the bottom and rear of the hood, you can see the tapered duct takeoff leaving from the ventilated headboard. At the end of the tapered takeoff is a quick connect fitting, which allows you to connect to either a single duct system or to a multi-duct system, such as we have set up in this room.
Adequate patient isolation is critical to reduce exposure and transmission.
Okay, so I think you have seen the video, and if you ask me how to reduce the risk, this is the best way to reduce the risk, what you have just seen in the video. Because the reason is all air will be circulated back to one channel to the box and go through the pre-filter, which is a low efficiency filter, and go straight to the HEPA filter, filter it, and exhaust it out to the environment. That's the best way to reduce the risk. So from there, we can we go back to the slide. Okay, I'll skip this PPE filter changing. This one, no, I don't go for that. Okay, ICU room. Okay, so ICU, I think if you demand for gases in ICU room, typically you will fit up with 3 outlets for total flow of about 1 SCM plus ventilator demand. So you have, I think COVID-19 patient will go into, some of them will go into the ICU because of the need of the ventilator, okay? And ventilator deliver gas to a patient based on their respiration rate and their lung capacity, okay? Ventilator can consume 100% MSA, 21% oxygen, and O2 oxygen all the way up to 0%. So 100% oxygen depending on the ability of lung to exchange gases in the bloods. So this one is for the oxygens, and medical surgical complex A typically fit up with 1 outlet for total flow of 1 cubic feet minutes plus ventilator demand. And also this one MSA demand add up to range 2 to 3 SCM. Ventilator multiple patients served by common is not recommended by medical. Okay, so this one I think we already practiced here, so I will skip this. Okay, so this one is very important for the operating room because, like I said just now, operating room is come with a 100% fresh air system. It is not the use of OT, OR or OT as COVID-19 patient room. I think is not recommended. Okay, as a temporary ICU is not ideal. Introduce additional rates and should be considered in relation to the current state of the epidemic. Okay, some area may not be available for use as facility. Re-establish elective services. So from ASHRAE guide from the epidemic task force, they recommend not to use OT as a temporary COVID-19 patient rooms.